Hello, fellow public health practitioners. Today I will be presenting to you the ethical issues that are relevant to palliative care in Australia. And today I will be presenting to you based on the findings of the Grantan Institute Dying World Report, which looks at the ethical issues pertaining to palliative care and how we as public health practitioners can promote this type of care to improve the quality of life in Australia. This case study reports on the limited promotion of palliative care services available in Australia, with only $5 billion a year being spent on the last year of life for older people in a health budget of $100 billion. It recognises the importance of the dying process on both patients and families, thus calling for public health practitioners to promote palliative care to improve quality of life in Australia. This case study reports on the limited promotion of Ethics are quite broad and subjective to individuals. They relate to the principles that govern one's behaviour or the course of action one will conduct. It is typically pertained on the basis of one's morality. When looking at this from a public health approach, public health ethics deals primarily with the moral foundations and justifications for public health, the various ethical challenges raised by limited resources for promoting health, and real or perceived tensions between collective benefits and individual liberty. In 2019, Lmh et al. Were specifically interested in the types of ethical issues faced by public health practitioners and were able to identify 5 broad categories of ethical issues that are common across all occupations and locations. The first one is determining appropriate use of public health authority. Second is making decisions related to resource allocation. After that comes negotiating political interference in public health practice. Fourth comes ensuring standards of quality of care. And lastly, questioning the role or scope of public health. While there is no specific code of conduct for public health practitioners, the Council of Australian Government's Health Council released a report in 2015 entitled A National Code of Conduct for Healthcare Workers. The report presents the findings and recommendations arising from a national consultation that sought views from the community and the health sector about the terms of the first National Code of Conduct for Healthcare Workers and how the National Code should be given effect in all states and territories. It will set national standards against which disciplinary action can be taken, and if necessary, a prohibition order issued in circumstances where a healthcare worker's continued practice presents a serious risk to public health and safety. As this presentation focuses on the ethical issues arising from palliative care, it is worthwhile to define what palliative care actually is. So according to the World Health Organization, palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. This case reports on the availability of palliative care services in Australia, or the lack thereof, specifically the lack of health promotion surrounding palliative care. A public health approach recognises the social determinants of health as central to health and well-being, therefore shaping end-of-life experiences, thus prompting the need for service provision and program planning by public health practitioners. Often issues surrounding palliative care are not discussed due to the sensitivity of death. However, this report encourages the promotion of mature discussions about a topic that many dislike but we cannot avoid. This report ensures that when death inevitably comes for each of us, we die comfortably in surroundings we would choose. Surveys consistently show that between 60 and 70% of Australians would prefer to die at home. Hospitals and residential care nursing homes are the least preferred places to die. Yet over the past 100 years, home deaths have declined and hospital and residential care deaths have increased. Today, only about 14% of people die at home. 54% die in hospitals and 32% in residential care. Australia's rate of deaths at home is comparatively low. About 30% of people 65 and over die at home in comparable countries including New Zealand, the United States, Ireland, and France, about double the Australian rate. Death has become an increasingly institutionalised and medicalised experience. Hospitalisations have increased significantly for older age groups. In the decade 2011 to 2012, the hospitalisation rate for those aged 85 increased by 35% for women and 48% for men. As Hurstvall et al. Point out, the concept of a good death has been superseded by the concept of a managed death, one that requires professional support and knowledge, and takes place in a hospital, or more rarely a hospice, resulting in modern death becoming cellular, private, curtained, individualized, and obscured. The issue raises ethical concern due to the quality of care provided to those throughout palliative care. If it is not tailored to meet patients' desires, we must ask how we are going to address this. Due to the complexity of this issue, several parties are involved, including the patients, their families and carers, public health practitioners, and palliative care services. As palliative care should be strongly responsive to the needs, preferences, and values of people, patients are concerned with their wishes on dying and their experience. They want their experience to be pleasurable and would want peace of mind knowing that their wishes are respected. Palliative care is a family-centered model of care, meaning that family and carers can receive practical and emotional support. There is evidence that supporting relatives' involvement with the dying person is an important aspect of end-of-life care for both patients and their families. Evidence has also shown that families and carers have a more accurate input on a dying person's wishes in comparison to healthcare professionals. Patients also develop a connection and/or attachment to their families and carers, which is exacerbated during palliative care. Public health practitioners have an involvement with palliative care due to the promotion of this care, along with program planning and evaluation of palliative care. Due to the emerging issues surrounding the lack of palliative care promotion, public health practitioners will have increased involvement in this new palliative care promotion. Quality palliative care is provided by healthcare workers who endeavour to maintain the dignity of the care recipient, their caregivers and family, work with the strengths and limitations of the care recipient and their caregiver's family to empower them in managing their own situation, act with compassion towards the care recipient and their caregivers and family, consider equity in the accessibility of services and in the allocation of resources, demonstrate respect for the care recipient, their caregivers and family, advocate on behalf of the express wishes of care recipients, caregivers, families and communities, are committed to the pursuit of excellence in the provision of care and support, and are also accountable to care recipients, their families, and the community. Due to the complexity the ethical issues that are relevant to this case study are autonomy, where patients have the right to choose or refuse the treatment; beneficence, a doctor should act in the best interest of the patient; justice concerns the distribution of health resources equitably; and dignity, where the patient and the persons treating the patient have the right to dignity. These principles are relevant to the case study as these together constitute part of the 6 values of medical ethics. They pertain to the case study due to the lack of application of these ethics for patients during palliative care. The study conducted by Fortner et al. In 2011 found that a significant number of patients experienced a lack of autonomy during palliative care, with a statistical significance of 0.04. This then links directly to the benefits of doctors or service provision, in this case acting in the best interest of the patient. There is also a lack of justice surrounding palliative care in terms of health expenditure, with only $5 billion a year being spent on the last year of life for older people in a health budget of $100 billion. In terms of dignity, patients should be able to feel their wishes are respected and action to be taken accordingly. This constitutes the basis of individualized palliative care. In order to ensure ethical practice during palliative care, increased and improved health promotion is necessary. This will also inform clinical practice. Advancements in palliative care can occur with an increase in health expenditure that will improve program planning and service provision. Public health practitioners are key enablers in this process, with their role of improving quality of life with a specific focus on the social determinants of health. According to the World Health Organization, the social determinants are the conditions in which people are born, grow, live, work, and age. These determinants can strengthen or undermine the health of individuals and communities. A public health approach recognizes the social determinants of health as central to health and well-being, and should therefore shape end-of-life experiences. Through the improved promotion of palliative care, the ethical issues of autonomy, beneficence, justice, and dignity could be addressed in order to improve quality of life for patients. Thank you for listening to my presentation.